So good morning to all my dear students. So myself, Dr. Nagarjuna, Faculty of Pharmacology. So on this occasion, once again, a thank to Government of Andhra Pradesh, JNTU Anantapur, JNTU Kakinada for providing a wonderful platform to the students to learn subject in online mode. And myself, I am the coordinator for GPAT cell in Raghavendra Institute of Pharmacy, Anantapur, as well as I am the coordinator for Hyderabad Academy and online GPAT Academy. I think yesterday I have seen the Venkatrao sir evening pharmaceutics classes. Myself and Venkatrao sir both are coordinators and running this Hyderabad Academy and online GPAT Academy, where we are providing coaching for the pharmacy students for GPAT examination since from last 10 to 12 years. And these are all our contact details. And today's our topic is drugs acting on cardiovascular system. See, in the last class, the men say that in the first class we discussed about pharmacodynamics. In the second class, we discussed about drugs acting on GIT, gastrointestinal tract. So today we will see the another important system in the pharmacology, that is CVS, cardiovascular system. So nothing but our topic is drugs acting on cardiovascular system. The same thing here also, yesterday itself I told you, there are three branches. Physiology means study of normal functioning. Pathophysiology means study of disorders. Disorder means altered function. Pharmacology means study of drugs. So always before going to see about the drugs, always before going to understand the mechanism of drugs, you should read in such a way that what is the normal function of the system, what is the altered function of the system, then what are the drugs. This is everywhere. Wherever you have studied about the any systems, first you should see what is the normal function of the system. If the function of the system gets altered, what type of disorders will come? What is the reason for the disorder? Then, based on that, what are the drugs and what are the mechanisms of drugs used to treat those disorders? So this is sequentially you have to see. So yesterday I told you GIT, what is the normal function, disorders and drugs. So today we'll move on to the cardiovascular system in the same way. I think everyone knows that. So what is the function of cardiovascular system? First we'll see the physiology in brief way, in a peripheral way. So we all know that a cardiovascular system, its function. See what they mentioned? The cardiovascular system refers to the three major components: heart, blood vessels and blood. So usually heart will pump the blood, blood vessels will supply the blood. And what is the role of blood here is? The blood is a carrier for oxygen and other all nutrients by which it will reach to various parts of the body. See, always you have to remember the heart will pump the blood to various parts of the body. The blood vessels will supply blood to various parts of the body. Why should we require supply of blood is the blood is a carrier for oxygen and nutrients through which all organs are getting oxygen and nutrients, which is essential for the survival of all parts of the body. Am I right? See, same thing. What they mentioned, the body takes all these essential nutrients from the blood, the different organs, At the same time, the body dumps waste products like carbon dioxide back into the blood, so they can be removed. So as we know that, right? The heart will pump oxygenated blood, purified blood to various parts of the body. The different organs utilize the oxygen and nutrients for their various functions. So because of the various functions, they will release carbon dioxide as a waste product. That carbon dioxide has to be removed from the body. So this is, that exchange of gases, intake of oxygen and removal of carbon dioxide. So cardiovascular system in collaboration with respiratory system will work out on the exchange of gases, and this is totally called as circulatory system. So usually the cardiovascular system is nothing but heart, blood vessels. Heart is for pumping of blood, but blood vessels are for supply of blood. So through blood, oxygen and nutrients reach to all parts of the body. The body parts will function, will work, and because of their function and metabolic works, they will release carbon dioxide as a waste product, and once again that carbon dioxide will be removed from the blood. This is how usually the circulatory system is maintained in our body. So if you see here, the major functions of the cardiovascular system is, so as I mentioned just now, so to transport nutrients, gases, and waste products around the body, to protect the body from infections and blood loss, and helpful to maintain the constant body temperature, thermoregulation, and to maintain fluid balance within the body. As we discussed, to transport nutrients, oxygen, to remove waste products, to protect the body from blood loss, infections, maintain the thermoregulation, fluid balance within the body. Now you see what is the functioning of heart and what is the functioning of blood vessels in a brief way. We are not going in detail once again. So everyone knows that. So what is the function of a heart and all, right? Heart is a muscular organ which pumps blood through the blood vessels, and this pumped blood carries oxygen and nutrients to the body. Just now explained to you. And the heart is a muscular organ which has the size of a fist. So which is a strong muscle and which is located on the left side of the body in humans, as we all know that. And coming to these blood vessels, this also we know that they are the part of the circulatory system. They transport blood throughout the body. They transport oxygen, nutrients, and blood cells to all tissues of the body. And they also remove waste and carbon dioxide away from the tissues. So this is how the blood vessels and heart collaboratively will work. Heart will pump the blood vessels will transport the blood. But coming to our point of view, so there are different ways of classification of blood vessels. So for our discussion, the blood vessels are classified into two types. So we have different classifications of blood vessels, am I right? Arteries, veins, arterioles, venules, capillaries. So likewise you can say. So our discussion majorly related to these two things. There are two types of blood vessels. So one is called as coronary blood vessels. Another is called as peripheral blood vessels. From the name itself, you can understand coronary blood vessels means the blood vessels which supply blood to the heart. So peripheral blood vessels means the blood vessels which supply blood to various parts of the body. Am I right? The blood vessels which transport blood to heart called as coronary blood vessels. The blood vessels which supply blood to various parts of the body called as peripheral blood vessels. Now we'll move on to the disorders. Just now I told you a brief functioning. So once again in detail about the physiology, everything and all we'll see in each and every disorder. First we have a look onto the definitions of disorders. First, before going to the drugs, pharmacology, treatment, you should know the first basic definitions of every disorder. That is very important. So what are the disorders of cardiovascular system is? The first major disorder is congestive heart failure, also called as congestive cardiac failure. Nothing but CHF, also called as CCF. So have a look on this. Clearly try to understand. Congestive heart failure, also called as congestive cardiac failure. So what is the meaning and what is the definition for this disorder is? It is a condition You please try to understand. If you understand these disorders, then only you understand the drugs, then only you understand the pharmacology. You have all studied, you have all read all these disorders, but you should know exactly what is happening in these conditions, what is the exact definition for these disorders. The first one, congestive heart failure. What is this condition is failure of the heart to pump sufficient blood to various parts of the body. Try to understand. From the name itself, you can understand. It is a condition where the heart is unable to pump sufficient blood to various parts of the body. See, I'm using the word. This is very important. You should always. Sufficient is very important. You should not say that heart is unable to pump blood. That is wrong. If you say that heart is unable to pump the blood, that is wrong. What is the meaning of that? Heart is unable to pump the blood means heart is not working. Heart muscle is died. That is called as death of the heart muscle, heart attack. So that is not here. The heart is unable to pump sufficient blood to various parts of the body. That is called as congestive heart failure. In the congestive heart failure, there is no death of the patient, nothing else will be there. The heart is not able to pump sufficient blood to various parts of the body. As a result, what happened? The blood supply decreases to various parts of the. This is very important. So many students will tell that blood supply decreases to heart. That is wrong. I'm telling that congestive heart failure is a condition where the heart is not able to pump sufficient blood to various parts of the body. Because of this condition, blood supply decreases to various parts of the body. That's all. This is exactly called as congestive heart failure. See here. So normal versus congestive heart. This congestive heart failure may have various reasons. One of the reasons is this thickening of ventricular chambers. So whenever these chambers will thicken, automatically the smaller ejection of blood. There, the heart is unable to eject sufficient blood to various parts of the body. So coming to the next disorder, atherosclerosis. So what is this atherosclerosis is? It is characterized by the, we all know that, deposition of lipids and lipid related materials like any cholesterol, triglycerides, lipoproteins in the blood vessels, especially in the coronary blood vessels. That is very important. So this is most important. Atherosclerosis means deposition of lipids or any lipid related materials like cholesterol, triglycerides, lipoproteins in the blood vessels, especially in the coronary blood vessels. So whenever the lipids are deposited in the coronary blood vessels, automatically blood supply decreases to heart, because as I mentioned earlier, the function of coronary blood vessels is supply of blood to heart. When something is deposited in coronary blood vessels, blood supply decreases to heart. This is very important. In CHF, blood supply decreases to various parts of the body. In atherosclerosis, blood supply decreases to heart. That's all. So that is what I told in the beginning also. That's why it is called as a disorder. A disorder means altered, abnormal, increases or decreases. Everyone is having cholesterol in the blood. It is not abnormal. But excess cholesterol in the blood is called as atherosclerosis. Everyone is having glucose in the blood. Excess glucose in the blood is called as diabetes. Everyone is having acid secretion. Excess acid secretion leads to ulcers. That is a disorder. So that is a try to understand. I'm conveying you. There is a difference between the normal and disorders. The same functioning is becoming abnormal. Increases or decreases called as disorders. So this is what another representation for atherosclerosis. See here, this is what the normal artery, the normal blood vessels. And this is, see here, the plaques are accumulated. The cholesterol gets accumulated like this. in the coronary artery. Automatically blood supply decreases to it. See, this is the normal blood flow. So like cholesterol, plaques are deposited. So automatically blood supply will be decreases. So coming to the next condition, angina pectoris. So what is this angina pectoris is? So we all know that it is simply the development of pain in the chest. It's a pain syndrome. The people are having chest pain. So because of decreased blood or oxygen supply to muscle of the heart, myocardium, the individuals are developing pain in the chest because of decreased blood supply to muscle of the heart, myocardium, called as myocardial ischemia or myocardial hypoxia. Always ischemia means lack of blood supply, hypoxia means lack of oxygen supply. So why blood supply decreases to cardiac muscle is one of the reason is deposition of lipids, atherosclerosis. So once again, angina pectoris will have several reasons. One of the main reason is atherosclerosis. Got it now? If any individual is having atherosclerosis, lipids are accumulated, blood supply decreases to heart. Slowly, if you have not controlled atherosclerosis, it leads to pain in the chest. That pain in the chest is called as angina pectoris. See here, likewise, the pain in the chest will start. Usually, it distributes to other parts of the body also. See, ischemia, heart muscle is not receiving enough oxygen. So next is myocardial infraction. So as you know that infraction is nothing but tissue death. As you studied necrosis, necrosis is a cell death. This is infraction, tissue death. Myocardial infraction means death of the myocardium. Why any tissue will die? The death of the tissue is because of lack of oxygen supply, lack of blood supply to myocardium for a very longer period of time. If there is no blood supply to one tissue for a very long period of time, automatically tissue will die. So that is what happening here. So death of the myocardium due to less or complete absence of oxygen supply for long period of time is called as myocardial infraction, which is also called as heart attack. So why this myocardial infraction will come is one of the major reason is angina pectoris. Am I right? So please try to understand these are all three are same, almost same. The severity is different. Atherosclerosis means lipids accumulated in coronary blood vessels. Blood supply decreases to cardiac muscle. If you have not controlled atherosclerosis, it slowly develops pain in the chest, which is called as angina pectoris. The pain in the chest due to lack of oxygen supply to myocardium. If angina pectoris is not controlled, automatically slowly, less oxygen supply for long period of time, the tissue will die, called as myocardial infarction, which is also called as heart attack. So the people who are having these angina pectoris, they are more prone to develop the myocardial infarction. So that is what we are seeing in the outside also. Actually speaking, myocardial infarction means heart attack, means death of the myocardium, means death of the cardiac muscle. Heart muscle will die, heart is not pumping, heart is not working. That indicates death of the patient. So actually speaking, a person can develop myocardial infarction, heart attack in a life only one time. So once heart attack comes, death of the myocardium takes place, the person will die. But in the outside we are speaking, heart attack first time came, second heart attack likewise. Actually they are not exactly speaking as heart attacks. They should not refer as heart attacks. They should refer as anginal attacks. So myocardial infarction will not come suddenly. Who will develop myocardial infarction is who are having angina pectoris. So whenever this angina worsens, whenever this angina severes, the persons develop more pain in the chest. That is usually we call as heart attack. It is not actually called as a heart attack. It should call as anginal attacks. So first heart attack, the next time the person should be more cautious. Likewise, you are speaking, right? So that means if any person is having anginal attacks, the next step is itself he can develop myocardial infarction. So that's why we are saying that the individual who is having the anginal attacks, the person has a more chance for death in the next time. This is the thing we have to understand. But the myocardial infarction is at end stage, death of the myocardium, the person will die here. So this is once again. So damage and death of the heart tissue shown in the purple color. So this coronary artery gets blocked with plaques. Because of that, there is cardiac muscle, blood supply decreases. So the muscle was died. So it shows in the purple color. So this is death of the myocardium. And we all know that the hypertension, as we know that everyone is having blood pressure, the altered blood pressure, increase in blood pressure called as hypertension, decrease in blood pressure called as hypotension. As you know that the normal is 120/80. So we can say 90 to 120 is systolic considered as a normal, 60 to 80 diastolic is considered as a normal. So below which and above which is considered as hypotension and hypertension. That will come in detail next cases. And last one, we all know that arrhythmias. So irregular or abnormal heartbeat called as arrhythmias. Abnormal heart rhythm, you can say that. The heartbeat maybe increases or decreases. See, the arrhythmias is a disorder which is related to the number of heartbeats. Have a clarity on this? Arrhythmias related to the number of heartbeats. Irregular heartbeat. The heartbeat increases or decreases is called as arrhythmias. So this is what about the disorders of cardiovascular system. So you should know the definitions clearly about this. So I'm telling clearly, the heart is an organ responsible for pumping of blood. The blood vessels are components responsible for supply of blood. Coronary blood vessels supply blood to the heart. Peripheral blood vessels supply blood to various parts of the body, periphery. So what are the disorders? Congestive heart failure. The heart is unable to pump sufficient blood to various parts of the body. As a result, blood supply decreases to various parts of the body. So this. Atherosclerosis, lipids, cholesterol get accumulated in the blood vessels, especially in coronary blood vessels. As a result, blood supply decreases to cardiac muscle. Angina Pectoris, the person develops pain in the chest due to insufficient blood or oxygen supply to myocardium. So many reasons will be there. One of the main reasons is atherosclerosis. Myocardial infraction, death of the heart muscle due to prolonged lack of oxygen supply to myocardium. One major reason is angina pectoris. So increased blood pressure called as hypertension, decreased blood pressure called as hypotension. So arrhythmias related to the number of heartbeats. Heartbeat maybe increases or decreases, the irregular abnormal heartbeat. Now, we'll move on to the one by one disorder. This is just a basic introduction. Up to now we discussed what are the components, function, definitions of disorders. So now we'll move on to the exactly one by one disorder. The first disorder we'll speak here is arrhythmias. The first disorder, what we are going to discuss here is arrhythmias. As I told you, arrhythmias means abnormal heartbeat, irregular heartbeat, heartbeat maybe increases or decreases. So to understand about all these disorders, drugs and all, first we should have idea on the electrophysiology of cardiac cell, the fundamentals once again. See here, first one, arrhythmias, irregular abnormal heartbeat, heartbeat maybe increases or decreases. So if you want to understand about these arrhythmias, first you should know what is heartbeat, how this heartbeat is coming, what is the mechanism behind this heartbeat. All those things we have to know. So in that, the first concept here is electrophysiology of cardiac cell. So listen one by one. This is very important. If you understand all these things, you can understand about arrhythmias easily. I'm right now speaking how the heartbeat will come, what is the reason, mechanism behind the heartbeat, everything. Electrophysiology, you can say this. Electrophysiology of cardiac cell. In that, the first one. So impulse generation in the cardiac cell. So nothing but action potential generation in the cardiac cell. As you know that every cells in our body will continuously generate the impulse. Am I right? Now we are talking about the impulse generation in the cardiac cell. How a cardiac cell will generate impulse or action potential. So listen carefully. The first one is, I'm speaking one by one, RMP, resting membrane potential. The resting membrane potential for cardiac cell is minus 90 millivolts. So make a note here. The resting membrane potential for cardiac cell is minus 90 millivolts. Whereas for other cells in our body, it is minus 70. For cardiac cell, resting membrane potential is minus 90 millivolts. So next, this action potential, the impulse generation always begins with the opening of sodium channels. So whenever the sodium channels get opened, I told you already, the opening of sodium channels always cause influx of sodium ions. Am I right? So because of the opening of sodium channels, the influx of sodium ions will take place. So when the sodium ions enter into the cell, the positive ions enter into the cell, the potential will be increases because sodium carries positive charge. The potential will be increases. This is called as phase zero. See, they mentioned the sodium ions enter into the cell at a very fast rate of 10 to the power of 7 sodium ions per second. The first one, cardiac cell, resting membrane potential is minus 90. The impulse generation, action potential generation begins with the opening of sodium channels. When the sodium channels get open, automatically sodium ions enter into the cell at a very fast rate of 10 to the power of 7 sodium ions per second. When the sodium ions enter, they carry positive charge. The potential will be increases. This is called as phase zero. Right, move on to the next. After some time, means after some milliseconds, what happened? The sodium channels will be closed. Sodium channels will be closed. So whenever the sodium channels are closed, then there is an opening of potassium channels. So what happened? The potassium channel opening causes efflux of potassium because I told you the inotropic receptors. Sodium, calcium, chloride opening leads to influx. Potassium channel opening leads to efflux because always sodium, calcium, chloride are present outside the cell. So their channel opening always results in influx. Potassium is present always inside. Their opening leads to efflux. That is very important. You should not forget all these things. So whenever the sodium channels will be closed, then there is an opening of potassium channels that causes efflux of potassium. Potassium, positive charged potassium enters outside. As a result, potential will be decreases. This is called as phase 1. And next, after some time, so always sometime means milliseconds only. After some time, the potassium channels will be in the open state, and then there is an opening of calcium channels also. There is opening of calcium channels also. So as you know that when the calcium channels open, see the calcium channels will take place when the potassium channels are in the open state only. Now as a result, what happened? The calcium channels open means influx of calcium will happen. So efflux of potassium leads to, potassium channels opening leads to efflux of potassium. So what I told you, when the potassium channels are in the open state, the calcium channels also get opened. So what happened now? So due to opening of calcium channels, influx of calcium takes place. Due to opening of potassium channels, efflux of potassium takes place. Both the things will take place parallelly, influx of calcium and efflux of potassium. As a result, there is no change in the potential. So got it now? Because of influx of calcium and efflux of potassium, so one positive charged ion enter into the cell, another positive charged ions enter out the cell. There is no change in the potential, which is called as a plateau phase, phase 2. And next, after some time, once again, some after milliseconds, next what happened? The calcium channels will be closed. So when the calcium channels will be closed, what happened? There is only opening of potassium channels. Am I right? So when the potassium channels are open, there is a continuous efflux of potassium. Potassium carries positive charge. Due to efflux of potassium, potential will be decreases, called as phase 3. So got it now? In the phase 2, plateau, no change in the potential because of efflux of potassium and influx of calcium. But after some time, calcium channels will be closed and there is only opening of potassium channels, only efflux of potassium. Due to continuous efflux of potassium, potential will be decreases, which is called as phase 3. Now finally what happened at this stage? Sodium is present inside. Am I right? And potassium is present outside. Because during phase 0, all sodium will enter inside. Here all potassium will enter outside. Actually, I told in inotropic receptors, always potassium is present inside, sodium is present outside. But because of this impulse, changes happen. Sodium is present inside, potassium is present outside. Now, finally, what happened? There is an activation of the enzyme called as Na plus K plus ATPase. This enzyme will keep potassium inside and sodium outside. And finally, the cell reaches resting state, which is called as phase 4. Finally, there is an activation of the enzyme Na plus K plus ATPase, which will keep potassium inside and sodium outside. When the potassium comes inside, sodium comes outside, the cell reaches the resting stage. So the cell begins with the resting stage, and finally the cell should come to the resting stage. So this is what called as one complete impulse generation. Always the cells will generate the impulse when they are present in the resting stage. From the resting state, the cell reaches the resting state. In between, some changes happen, which is called as action potential generation or impulse generation. So this is somewhat a little bit confused, but just see here once again carefully. I'm telling you once again. Impulse or action potential generation in cardiac cell. So every cells in our body will generate the impulse. So right now we are speaking about the impulse generation in the cardiac cell. So RMP, the resting membrane potential for cardiac cell is minus 90 millivolts. At the resting stage, we all know that sodium is present outside, potassium is present inside. The first impulse generation, action potential generation, begins with the opening of sodium channels. When the sodium channels get open, sodium ions enter into the cell at a very faster rate of 10 to the power of 7 sodium ions per second. As a result, potential will be increases, which is called as phase 0. After some time, the sodium channels will be closed. Whenever the sodium channels are closed, there is an opening of potassium channels, causes efflux of potassium, then potential will be decreases, called as phase 1. And after some time, when the potassium channels are in the open stage, calcium channels also will be open. As a result, influx of calcium and efflux of potassium. Hence, there is no change in the potential, called as plateau phase, called as phase 2. And after some milliseconds, the calcium channels will be closed. Only opening of potassium channels, continuous efflux of potassium leads to decrease in the potential, called as phase 3. Finally, at this stage, sodium is present inside, potassium is present outside, present in opposite directions. Finally, there is an activation of the enzyme called as sodium potassium ATPase, which will keep sodium outside and potassium inside. Whenever the potassium comes inside, sodium goes outside, the cell reaches the resting stage called as phase 4. The cell starts with the resting state. Once the cell reaches the resting state, now the cell is ready for another impulse generation. Likewise, the impulse generation takes place with the help of different phases called as phase 0, phase 1, phase 2, phase 3, phase 4. Now have a look onto this. So totally impulse generation has 5 phases. So don't confuse, the number wise it is 4, but totally it is 5 because it starts with 0, 0, 1, 2, 3, 4. Always 0, 1, 2, 3, 4. Totally 5 phases. See, have a look onto this. This is resting membrane potential. Phase 0 means opening of sodium channels. Influx of sodium, increase in the potential. See. Next, sodium channels will be closed. Potassium opens. Efflux of potassium, decrease in potential. Phase 1. Next, opening of calcium also. So, influx of calcium, efflux of potassium. So, plates, no change in the potential. Next, calcium channels closed. Only opening of potassium, efflux of potassium. So, decrease in the potential. Finally, Na plus K plus ATPase activation. So, reaches to the resting state called as phase 4. Starts with resting, reaches to the resting. Again, generate the one impulse generation. Likewise, continuously impulse are generated by the cardiac cell. Just have a look onto this for just a few seconds. You will understand here. See here, phase 0, 1, 2, 3, 4. Opening of sodium channels, increase in the potential. Sodium channels close, potassium channels open, decrease in the potential. Opening of both potassium and calcium, flat phase, no change in the potential. Calcium channels close, only opening of potassium, efflux of potassium, decrease in the potential. So Na plus K plus ATPase activation will keep sodium outside and potassium inside. Cell reaches resting state. See here, 0, 1, 2, 3, 4. So increase in the potential, decrease in the potential, no change in the potential. The complete decrease in potential reaches to the resting state. Finally, you can see you should have good idea about these phases. The phase 0 is because of due to opening of sodium channels. So phase 1 is because of potassium channels. Phase 2 is due to opening of calcium channels. Phase 3 is due to opening of potassium channels. And phase 4 is because of activation of Na plus K plus ATPase. Summarize here. Phase 0 due to opening of sodium channels. Phase 1 due to opening of potassium channels. Phase 2 due to opening of calcium channels. Phase 3 due to opening of potassium channels once again. Phase 4 due to activation of Na plus K plus ATPase. See here, after this impulse generation, next concept is impulse conduction or impulse propagation. So after this impulse generation, how the impulse will be conducted? So conduction of impulse means movement of impulse from one area to another area. So where we have to understand the term called as automaticity. So what is the meaning of automaticity is the capacity to generate action potential on its own without any external stimulus called as automaticity. Capacity to generate action potential on its own without any external stimulus called as automaticity. And which is having this automaticity phenomenon is nothing but SA node. So we know that sinoatrial node is having the property of automaticity. Hence this SA node is otherwise called as pacemaker. So understand this? So after the impulse generation, next step is impulse conduction, impulse propagation. The impulse transmits from one area to another area. First, where impulse will be generated is in the SA node, because SA node is having automaticity. Automaticity means capacity to generate impulse on its own without any help. Hence, SA node is called as pacemaker. See here, first SA node having automaticity generate the impulse on its own without any help. From the SA node, impulse transfers to atria, atria to AV node, AV node to bundle of his to Purkinje fibers reaches to ventricles. This is how the impulse will be conducted. So most important, as you studied in the previous classes also, SA node to atria, atria to AV node to bundle of his to Purkinje fibers to ventricles. Yeah. So once the impulse conducts from SA node to ventricles, so once impulse conducts from SA node to ventricles, the ventricles undergo contraction, which is called as heartbeat. So which is nothing but your ECG. See, first impulse will be generated. Next impulse will be conducted. So impulse will be conducted from SA node to ventricles. So whenever the impulse is conducting from SA node to ventricles, ventricles undergo contraction, which is called as heartbeat. The heartbeats will be visualized in the form of ECG. The normal time taken for one impulse conduction is 0.8 seconds. So that's why our normal heartbeat is 72 beats per minute. So got my point. So why an individual is having 72 beats per minute is the time for one impulse conduction from SA node to ventricles is 0.8 seconds. After the generation of impulse in the SA node, in order to reach ventricles, it takes 0.8 seconds. That's why the number of heartbeats will be 72 beats per minute. Suppose if the impulse conduction time is 1 second, how many heartbeats will come? 60 beats will come. So that means likewise you have to understand. So actually normally one cardiac cycle, one impulse conduction time is 0.8 seconds. Henceforth, the total number of heartbeats will be 72 beats per minute. So always the number of heartbeats depends upon the time taken for impulse conduction. Our impulse conduction time is 0.8 seconds. Henceforth, the normal heartbeat is 72 beats per minute. If the impulse conduction time changes, automatically the number of heartbeats will change. This is what one of the reasons for arrhythmias. And coming to the ECG here, so one ECG, EKG, called as electrocardiogram. So I told you already. So one ECG electrocardiogram is nothing but your heartbeat, ventricular contraction. So depicts and indicates one impulse generation and conduction. So what this ECG will represent is, this ECG will represent one impulse conduction. The first step is what? Impulse generation in the SCA node. So this line is because of SCA node depolarization. From SCA node to atria. So this P wave is because of atrial depolarization. Next, from atria to AV node, bundle of is Purkinje fibers. So this is all because of AV node, bundle of is Purkinje fibers. From which impulse reaches to ventricles. This is because of ventricular contraction. Finally, this is because of ventricular relaxation. Up to this only. This is one ECG. And this line is 1 second because of SCA node. From the ECG, in the ECG, every line and every wave is having certain meaning. It depicts a complete impulse conduction. This line is because of SCA node, this is because of atria, this is because of AV node, bundle of is Purkinje fibers. This is because of ventricular depolarization. There is the last part. So ventricular depolarization, ventricular contraction followed by ventricular relaxation. So with this one ECG is completed, one heartbeat, one impulse conduction. This is once again fresh SCA node. So what is the point you have to understand is one impulse generation followed by one impulse conduction. One impulse conduction from SCA node to ventricles will give one ventricular contraction, nothing but one heartbeat, nothing but one ACG. So this is a sequence you have to understand. So please, if you understand this, you can understand about arrhythmias very easily. The first cardiac cell will generate the impulse where the resting membrane potential is minus 90. Sodium channels will be open, phase 0. Sodium channels closed, potassium channels open, decrease in the potential phase 1. Calcium channels also will be open, both are in the open state. Plateau phase, no change in the potential. Closing of calcium channels, only opening of potassium, rapid decrease in the potential, phase 3. Na plus K plus activation. Sodium will send outside, potassium will come inside, cell reaches resting. So this is 0, 1, 2, 3, 4. The 0 phase is because of sodium channels. First phase is because of potassium channels. Second phase is because of calcium channels. Third phase is because of potassium channels. Fourth phase is because of Na plus K plus ATPase. So once one impulse will be generated, the impulse will be conducted. From where it is conducted is from the SCA node, because SCA node is having automaticity called as pacemaker. From the SCA node, the impulse moves to atria, atria to AV node to bundle of his to Purkinje fibers to ventricles. So one impulse conducts to ventricles. You will observe one heartbeat, nothing but one ECG. The time for one this cardiac cycle and impulse conduction is 0.8 seconds. That's why we have number of heartbeats are 72 beats per minute. Once the impulse conduction time changes, the number of heartbeats also will be changed. This is the reason for arrhythmias. So ECG depicts a complete impulse conduction. The first line is because of SCA node. This is because of atria. This is because of AV node, bundle of his Purkinje fibers. This is because of ventricular contraction, ventricular relaxation. Out of all these, why this QRS complex is very high T is, this QRS is because of ventricular contraction. Compared to all parts of the cardiac cell, ventricles have more contraction capacity. We know that ventricles are majorly responsible for pumping contraction. So ventricles will have more contraction. That's why we have QRS complex is a big complex. So move on to the next disorder related to all these things is arrhythmias. It's clear. So move on to all these things. So after the completion of all these things, so the disorder related to all these fundamentals is arrhythmias. So what are arrhythmias? We all know that. I already told you abnormal heartbeat or irregular heartbeat. The heartbeat maybe increases or decreases. So normal heartbeat is 72 beats per minute. The normal heartbeat range is 60 to 100 beats per minute. So coming to this definition, you please try to understand. Arrhythmias means abnormal or regular heartbeat. The heartbeat maybe increases or decreases. So normal heartbeat is 72 beats per minute, but the normal heartbeat range is 60 to 100 beats per minute. So because no individual is having 72 beats per minute at a time, because the heartbeat is highly variable, the heartbeat is influenced by several factors. The heartbeat is influenced by your sleep pattern, your stress pattern, your food pattern, your body posture, whatnot. Every factor will influence the heartbeat. It is going to vary from one time to other time. So no individual is having 72 beats per minute in all the times. It is a highly variable factor. The normal heartbeat range is 60 to 100 beats per minute. So always you are saying that the person is suffering from arrhythmias when it is below 60 and when it is above 100. So which are of two arrhythmias divided into tachyarrhythmias and bradyarrhythmias. So tachyarrhythmias means above 100 beats per minute. Bradyarrhythmias means less than 60 beats per minute. So try to understand 60 to 100 is a normal range. Below 60 beats per minute called as bradyarrhythmias, above 100 beats per minute called as tachyarrhythmias. But most of the individuals, almost all the persons are only suffering from tachyarrhythmias but not from the bradyarrhythmias. Out of the arrhythmias, the most of the people only suffering from tachyarrhythmias but not from bradyarrhythmias. So based upon our discussion, now can you tell me what are the reasons maybe responsible for tachyarrhythmias, maybe responsible for bradyarrhythmias? So you take a paper, you try to sort it out. You only try to write what are the reasons maybe responsible for tachyarrhythmias, what are the reasons maybe responsible for bradyarrhythmias. So I'm telling you clearly, tachyarrhythmias means above 100 beats per minute, means heartbeat increases. I told you already what is the reason for heartbeat. See, try to understand the sequence. Impulse generation. One impulse generation followed by one impulse conduction. One impulse conduction to ventricles will give one heartbeat, one ECG. So tachyarrhythmias means increase in heartbeat. I'm telling you the normal time for impulse conduction is 0.8 seconds. So that's 72 beats per minute. When the impulse conduction time changes, number of heartbeats also will change. And once I'm repeating, one impulse generation followed by one impulse conduction. One impulse conduction to the ventricles will give one heartbeat or one ECG. Normal time is 0.8 seconds, so that's 72 beats per minute. I'm telling that the arrhythmias, if a person is having heartbeat increases or decreases, tachyarrhythmias means above 100 beats per minute, bradyarrhythmias means less than 60 beats per minute. Based upon all our discussion, you write it on your paper or book. What are the reasons? Maybe just you think on your own. Maybe responsible for tachyarrhythmias, increase in heartbeat. Maybe responsible for bradyarrhythmia, decrease in heartbeat. So see here and write it. Okay. So just I will come back within just 3 to 5 minutes. You please try to think it of tachyarrhythmias. What are the reasons may be responsible? Bradyarrhythmias. What are the reasons may be responsible with our SL discussion? So if you are able to write, you can understand about the cardiac system. So just 3 to 5 minutes, you write it and you try to sort it out. All these things. Okay. So we'll come back to this discussion. I think you have listed out the reasons for tachyarrhythmias and bradyarrhythmias. So first you will see here the reasons for tachyarrhythmias. So what are the reasons for tachyarrhythmias is, so just now I told you, increased heartbeat above 100 beats per minute. The worst reason is increased impulse generation in SCA node. Increased impulse generation in SCA node. Am I right? When the impulse generation increases, automatically the number of heartbeats will be increases. So this increased impulse generation in SCA node is because of the increased activity of sympathetic nervous system. So I told you yesterday also, the reason for disorder is disturbance in the homeostasis, disturbance in the balance. So always sympathetic and parasympathetic should be in the balance. So whenever it becomes imbalanced, leads to disorders. So tachyarrhythmias means so increased impulse generation in SCA node because of the excessive activation of sympathetic nervous system. So you have to always understand that the reason for any disorder is that anything that may be, I'm using this word always, increased activity. Something is going to happen, right? Either decreases or increases. That is very important. Our duty is we have to find out which is increasing, which is decreasing. Based on that, we have to go for agonist and antagonist. I told you in the first class itself, every drug in pharmacology is two types, either agonist or antagonist. So we have to find out which is decreasing, which is increasing, so we can go for the treatment. And the next reason for tachyarrhythmias is fast impulse conduction. So fast impulse conduction means the normal time is 0.8 seconds. The time required for impulse conduction decreases, less than 0.8 seconds. If the impulse is conducting very fast, the time is decreased, automatically number of impulses will be increases, number of heartbeats also will increase. Am I right? The normal time is 0.8 seconds. If the impulse is conducting within 0.4 seconds, more number of impulses, heartbeats also will be increases. That is the reason for tachyarrhythmias. So another reason is echotopic foci. So what is the meaning of this echotopic foci and focus is, apart from the SCA node, other parts, other areas also exhibit the property of automaticity. Actually, automaticity is only by SCA node. In some individuals, because of some genetical errors, apart from SCA node, other areas also show the property of automaticity. If other things also show automaticity, number of impulse generations will increase, number of heartbeats will increase. So this is the reason for tachyarrhythmias. So coming to bradyarrhythmias, less than 60 beats per minute. So what is the major reason for bradyarrhythmias is, first one, as usually, decreased impulse generation in SCA node because of the excessive activation of parasympathetic nervous system. See here, where excessive activation of sympathetic, here excessive activation of parasympathetic. Next is fast impulse conduction, here slow impulse conduction. So time required will be increases. When the time is more, number of impulses decrease, number of heartbeats also will decrease. And third reason is heart block. If heart block takes place, so heart block means blockade in cardiac cell. If the blockade takes place in cardiac cell, there is no further impulse conduction. So let us assume, what is the impulse conduction we told? SCA node to atria to AV node, bundle of his Purkinje fibers to ventricles. Suppose if the blockade takes place in the AV node, if the blockade takes place in AV node, what happened? Further impulse is not conducted to ventricles, automatically heartbeats will not be generated. So I mean to say that the partial heart block. So don't feel that complete heart block. So if AV node will be blocked, there is no conduction, no heartbeat, no functioning of heart, not like that. So heart block means a partial blockade. So likewise, once in heart block will have first degree, second degree, third degree, depends upon the intensity. So coming to the drugs and their mechanism, examples. So antiarrhythmics means which are used for the treatment of arrhythmias. preferably for the treatment of tachyarrhythmias. Just now I told you, if you speak about arrhythmias, most of the individuals are suffering from tachyarrhythmias. That's why if you see antiarrhythmics in general, the drugs used for arrhythmias, but mostly all those drugs are for the treatment of tachyarrhythmias. So whatever the examples, whatever the classification, everything what we see in the textbooks, all those drugs are for the treatment of tachyarrhythmias. So you only tell me now, what is the treatment for tachyarrhythmias? As I told you, the 99% of the arrhythmic patients are suffering from tachyarrhythmias. Now, antiarrhythmics means drugs used for the treatment of tachyarrhythmias. So now, what a drug has to do in order to treat tachyarrhythmias? With our earlier introduction, with all of our understandings and basics, you only tell me what a drug has to treat tachyarrhythmias. So simple thing here. So if your drug wanted to treat tachyarrhythmias, so what? See, simple, very simple. If you want to treat tachyarrhythmias, what you have to do? You have to decrease the number of heartbeats. Am I right? How will you decrease the number of heartbeats? By decreasing impulse generation. See, coming to the first once again. If you decrease the impulse generation, impulse conduction will be decreases, number of heartbeats will be decreases. Am I right? That is a treatment for tachyarrhythmias. How will you decrease this impulse generation? How will you inhibit the zero phase? By blocking sodium channels, called as sodium channel blockers. How will you inhibit this first and third phase? By using potassium channel blockers. How will you inhibit this second phase? By using calcium channel blockers. Clear now? If you want to treat tachyarrhythmias, you have to decrease the number of heartbeats. You will decrease the number of heartbeats by decreasing the impulse generation. How will you decrease the impulse generation is by inhibiting the phases. You are inhibiting the zero phase by using sodium channel blockers. You are inhibiting this phase 1 and phase 3 by using potassium channel blockers. You are inhibiting this phase 2 by using calcium channel blockers. And apart from, what is the other reason for tachyarrhythmias? The increased activity of sympathetic nervous system. So that which drugs we have to use? Agonists or antagonists? Antagonists. Antagonist to sympathetic nervous system means what? Sympatholytics. Sympatholytics means alpha and beta blockers. So I told what are the receptors located in heart? Beta 1. So that we are using specifically beta blockers, especially beta 1 blockers. So finally, all these antiarrhythmics are classified into 4 types. That's fine. The class 1 drugs are sodium channel blockers. Class 2 drugs are beta blockers. Class 3 are potassium channel blockers. Class 4 are calcium channel blockers. So get it now. Class 1 sodium channel blockers. Class 2 beta blockers. Class 3 potassium channel blockers. Class 4 calcium channel blockers. If you see these class 1 drugs, they are further divided into 3 types, 1A, 1B, 1C. So 1A includes quinidine, procainamide, disopyramide. So 1B includes lignocaine, tocainide, phenytoin. 1C includes flecainide, propafenone, morphine. All these drugs are classified based upon their association dissociation. So 1A means intermediate association dissociation. 1B fast association dissociation. 1C slow association dissociation. Fast association means they fastly block the sodium channels. Fast dissociation means they fastly dissociated from sodium channels. So means this classification is based upon onset of action and duration of action. So based upon this onset of action is very fast for 1B. Am I right? Duration of action is very long for 1C. Because of slow dissociation, they are slowly dissociated. Long duration of action will be there. So that's why if you see, the onset of action is in the order of onset of action. 1B first, 1A, next 1C. So 1B, 1A, 1C. Duration of action is in the order of longest duration for 1C, 1A, 1B. Right. So this is the classification based upon onset of action and duration of action. If you see some of the points, so quinidine, we all know that it is an alkaloid from cinchona. All cinchoalkaloids in higher doses produce a synchronism where we have tinnitus, disturbance in the ears, ringing sound in the ears. So procainamide, which is an amide derivative of local anesthetic drug procaine. So disopyramide is a drug having anticholinergic side effects like dry mouth, dry skin. So lignocaine is a local anesthetic. We all know that all local anesthetics are sodium channel blockers. So our class 1 drugs are also sodium channel blockers. That's what we are using. So this drug undergoes high first pass metabolism, so that this is not given by oral, given by IV. Lignocaine also called as lidocaine, xylocaine. So phenytoin also used as anti-epileptic agent. So one of the mechanism for anti-epileptic drugs are sodium channel blockers. Actually, if you speak here, the sodium channel blockers is a mechanism. The sodium channel blockers have therapeutically 3 uses. What are those 3 uses? Is sodium channel blockers are used as anti-epileptics, antiarrhythmics, local anesthetics. But only thing is site of action is different. If the drugs block sodium channels in the central nervous system, in the neurons, they are used to treat epilepsy. Because we know that epilepsy means excessive firing of neurons, excessive impulse generation in the neurons. In the impulse generation, the major phase is opening of sodium channels. Sodium channel blockers are used to treat arrhythmias when they block sodium channels in the cardiac cell. And they are also used as local anesthetics, means they block sodium channels in the local area. Means depending upon the site of action, sodium channel blockers therapeutically will have 3 uses. If they block sodium channels in the CNS neurons, they are used to treat epilepsy. If they block sodium channels in the cardiac cell, they are used to treat arrhythmias. If they block sodium channels in the local area wherever you apply, they are used as local anesthetics. Coming to the class 2 drugs, beta blockers, they are classified into non-selective beta blockers and selective beta 1 blockers. So I think we all know that non-selective beta blockers means which block beta 1 and beta 2, which also block beta 2 receptors present in bronchi, causes bronchoconstriction. Examples of propranolol, pindolol, timolol, sotalol. And we are highly preferring selective beta 1 blockers like atenolol, acebutolol, bisoprolol, nebivolol. Coming to class 3 drugs, which include bretylium, amiodarone, sotalol. So where sotalol is seen in the class 2 also, sotalol acts as both class 2 and class 3, and others are bretylium and amiodarone. So amiodarone is having iodine. Because of this, drug causes some bluish gray color to the urine. Class 4 drugs, what we use are verapamil and diltiazem. Only verapamil and diltiazem are used for arrhythmias. Because other calcium channel blockers like dihydropyridine group, amlodipine, nifedipine, nitrandipine, they are blocking calcium channels only in the blood vessels, but not in the heart. To treat arrhythmias, we need blockade of calcium channels in the cardiac cell, so that we are using only verapamil and diltiazem. We are not using these drugs. So this is all the drugs used for tachyarrhythmias, class 1, class 2, class 3, class 4. And I told you very few patients are suffering from bradyarrhythmias, and the drugs used for bradyarrhythmias include anticholinergics. As you know that acetylcholine decreases heart rate, so that we are using anticholinergics, majorly atropine. Next, sympathomimetics, because for tachyarrhythmias we are using sympatholytics, beta blockers. So here we are using sympathomimetics, especially beta 1 blockers, beta 1 agonists, because beta 1 is located in heart. So beta 1 agonist is dobutamine. So these are all the drugs used for bradyarrhythmias. So clear. So this is the what you can see this the treatment of arrhythmias. So treatment of both tachyarrhythmias and bradyarrhythmias. So what is impulse generation? What is impulse conduction? What is heartbeat? What is ECG? What are the reasons for tachyarrhythmias? What are the reasons for bradyarrhythmias? So what are the drugs used for tachyarrhythmias? What are the drugs used for bradyarrhythmias? So coming to other condition, so drugs for congestive heart failure. As I told you already, congestive heart failure is a condition. The heart is unable to pump sufficient blood to various parts of the body. As a result, blood supply decreases to various parts of the body. Speak about these chambers and blood flow of the heart. We all know that. And once I'm repeating, so I'm talking about the blood flow in the heart. So to understand this CHF, you should know about the flow of blood inside the chambers of heart. I think you have studied in your first year. I'm repeating. I'm peripherally once again. The normal blood flow in the heart. So we all know that the heart is having four chambers. The large chambers are called as ventricles. The smaller chambers are called as atria. The atria are upper chambers. The lower chambers are ventricles. See here, first you speak about right side. First, what happened? The superior vena cava carries blood from upper areas of the body. The inferior vena cava carries blood from lower areas of the body. This superior and inferior vena cava carry impure blood, deoxygenated blood into the right atrium. From the right atrium, blood enters into right ventricle through the opening of a valve called as tricuspid valve, made up of three flaps, three cusps. From the right ventricle, blood reaches to lungs, where blood undergoes purification. This oxygenated blood enters into left atrium. This blood enters from left atrium to left ventricle upon the opening of mitral valve, bicuspid valve. Finally, the left ventricle pumps the blood through aorta to various parts of the body. So try to understand the sequence. Superior vena cava carries blood from upper chambers of the body. Inferior vena cava carries blood from lower chambers of the body. Both will carry deoxygenated impure blood to right atrium. The blood moves from right atrium to right ventricle through the opening of tricuspid valve. From where the blood will enter into lungs, blood undergoes purification. The purified oxygenated blood enters into left atrium. From the left atrium, blood enters into left ventricle through the opening of bicuspid valve, mitral valve. Finally, left ventricle pump the blood to various parts of the body through aorta. See, if you compare this with the impulse conduction also. So I told you where impulse is generated, SCA node. From SCA node, impulse conducts to atria. When impulse reaches to atria, atria undergoes contraction. When the atria undergoes contraction, pressure in the atria will increase. Both things will take place simultaneously. Try to understand. Right and left side both will take place simultaneously always. So when the impulse conducts from SCA node to atria, atria undergoes contraction. When the atria undergoes contraction, the pressure in the atria will increase. Opening of tricuspid, opening of bicuspid valve will take place. Blood moves from right atrium to right ventricle, left atrium to left ventricle. Next, impulse also moves from atria to AV node, bundle of his, Purkinje fibers to ventricles. So when the impulse conducts to ventricles, ventricles undergo contraction. Due to ventricular contraction, the pressure in the ventricles will increase. When the pressure in the ventricles will increase, first these valves will get these valves will get closed to avoid backflow of blood. Then there is opening of pulmonary valve, blood enters into lungs. Opening of aortic valve, blood enters into aorta. Likewise, the impulse generation, conduction, blood flow will take place simultaneously within the 0.8 seconds. This entire process is called as cardiac cycle. See, try to have the right and left sides of the heart work together. See here, this is all. See, they mentioned clearly superior vena cava, inferior vena cava. So blood reaches to right atrium. This is tricuspid valve, right atrium to right ventricle. See, from the right ventricle to pulmonary artery reaches to lungs. Blood gets purified through pulmonary veins. Blood, oxygenated blood reaches to left atrium to left ventricle through this mitral valve. Finally, left ventricle pump the blood to this aortic valve. So aorta reaches to all parts of the body. Clear. This is what happened in the right side of the heart, left side of the heart. Same thing. Now, what is happening in the congestive heart failure is the blood reaches to left ventricle, but heart is unable to pump sufficient blood to various parts of the body. Am I right? So in CHF, what is happening? The blood reaches to left ventricle, but this left ventricle is unable to pump sufficient blood to various parts of the body. As a result, what happened? Blood supply decreases to various parts of the body. Blood gets accumulated in left ventricle. Slowly, blood gets accumulated in left atrium, slowly in the lungs also, because from where it is coming. Once left ventricle clears, blood moves from here. When the blood is present here only, will be stored in the left atrium, blood will be stored in the lungs. As a result, some problems will happen in CHF. The first symptom is fatigue tiredness. The CHF patients are feeling tiredness because of less blood supply to all parts of the body, because our body parts are not getting oxygen and nutrients. Next is dyspnea, breathlessness, because of blood gets accumulated in the lungs. The heart congestion, congestive heart feels some discomfort because blood gets accumulated in the heart. Now coming to the treatment of CHF. So to treat CHF, we have to increase the force of contraction. Make a note here. This is very, very important. See, if you see this heartbeat, heart contractions, the heartbeat is having two properties. One is the number of contractions, another is the force of contraction. So both are very important. So both are different. Heartbeat contractions are having two phenomena, two dimensions, two properties. One is the number of contractions, another is the force of contraction. How many times heart is beating is called as number. With how much force heart is beating is called as force of contraction. Make a note. This is try to understand. Both are very different. Heart is beating, heart is contracting. How many times heart is contracting is called as number of contractions. With how much force heart is beating is called as force of contraction. So to treat congestive heart failure, we have to increase the force of contraction. See, heart is not able to pump sufficient blood. So there is a problem in the force of contraction. See, if you take a syringe, you take a water into the syringe. If you touch the plug, the touching is called as number. How many times you are touching is called as number. With how much force, with how much pressure you are applying is called as force of contraction. So got my point? So how many times you are touching the knob is called as number of contractions. With how much force you are pressing is called as force of contraction. If you take the water into syringe, if the water come out of the syringe, what you require? Force is required. If you simply touch the knob, number is there, no use. Force is required. So try to understand, in to treat the CHF, we have to increase the force of contraction. So this is very, very important. See, the disorder related to the number of contractions is arrhythmias. The disorder related to the force of contraction is CHF. Please try to understand. Arrhythmias and congestive heart failure both are related to the heartbeat only. But arrhythmias related to the number of heartbeats. CHF is related to the force of heartbeats. So finally, our conclusion is to treat CHF, we have to increase the force of contraction. How will you increase the force of contraction? The force of contraction depends upon two things. One is calcium and cyclic AMP. As you know that calcium is responsible for contraction, force of contraction. Cyclic AMP, I discussed in the first class. So one of the second messenger in adenyl cyclase pathway is cyclic AMP. The action of cyclic AMP in heart is increase in the force of contraction. So to treat CHF, we have to increase the force of contraction. To increase the force of contraction, we have to increase calcium and cyclic AMP. So that the mechanisms of drugs for CHF include the drugs which increase the levels of calcium and the drugs which increase the levels of cyclic AMP. Finally, the mechanisms for CHF include drugs which increase the levels of calcium, drugs which increase the levels of cyclic AMP. Now we'll see one by one. So drugs which increase the levels of calcium are cardiac glycosides, which include your digitalis, tropanthes, quill, and thivacia. As you know that digitalis, two species, Purpurea lanata. Purpurea species is having digitoxin, lanata is having digoxin. Strophanthus has two species, Combe and Gratus. Combe having K-stropanthin, Gratus having G-stropanthin, also called as avovoid. If you come into the mechanism of cardiac glycosides, so I already mentioned you, the cardiac glycosides come under drugs which increase levels of calcium. But how they increase levels of calcium is, see here, somewhat little bit confused. These cardiac glycosides inhibit sodium potassium ATPase. I told you already, sodium potassium ATPase is what is the role? Phase 4, maintaining resting state, which is responsible for sodium potassium ATPase is responsible for keeping sodium outside, potassium inside. Am I right? Then cell reaches resting stage. If you inhibit this sodium potassium ATPase, sodium will not go outside, potassium will not come inside. So it increases the intracellular levels of sodium, which also increases intracellular of calcium, which increase the force of contraction. I'm showing here. See, this is what done by Na plus K plus ATPase. So what I told, the normal function of this pump is the 3 sodium will get outside, 2 potassium will come inside. So maintaining resting state. This is what we discussed. But in the cardiac cell, we have a sodium calcium exchanger pump also. So what is this role is? When the 3 sodium enter outside, 2 potassium enter inside, cell will come resting state. The role of is through this sodium calcium exchanger, another transporter we have, the 3 sodium will enter outside, right? The same sodium will enter inside, the calcium will enter outside. See, this is not involved in impulse generation, don't get confused. Up to this only impulse generation. Sodium potassium ATPase phase 4 resting membrane potential. 3 sodium will come outside, 2 potassium come inside. But through the sodium calcium exchanger pump, these 3 sodium will come inside, the calcium enter outside. Normally, I'm telling, normally I'm speaking. But what these cardiac glycosides are doing is they are inhibiting this enzyme. If you inhibit this enzyme, sodium will present inside. So sodium will not come outside. Sodium will be present here only. As a result, what happened? This sodium cannot come inside. So calcium cannot enter outside. What happened? Actually, these 3 sodium will come outside. The same sodium will come inside. When the sodium come inside, calcium will enter outside. But cardiac glycosides inhibit this enzyme. When you inhibit this enzyme, sodium will be present here only. As a result, the sodium cannot come inside, so calcium cannot go outside. So calcium inside the cell will increase. So that is what we are telling. Inhibition of sodium potassium ATPase, intracellular sodium increases. So as a result, intracellular calcium also increases, which increases the force of contraction. See, don't confuse. This is not involved in impulse generation. This is exchanger. So you are inhibiting this enzyme. Sodium will be inside. So sodium cannot come inside, calcium cannot go outside, calcium will increase. This calcium, by interacting with ryanodine receptors, increases the force of contraction. See the other representation. See sodium, potassium ATPase. Sodium out, potassium in. This out sodium come in, calcium out. But if you stop this, sodium will not go out. So calcium also will not go out. Calcium increases. Intracellular sodium increase, intracellular calcium increase. So pharmacological actions, if you see cardiac glycosides, there are two important properties. One is inotropic. Inotropic action means force of contraction. Chronotropic action means number of contractions. I told you heartbeat, heart contractions having two phenomena, two properties. One is the force, another is the number. Force of contraction is called as inotropic. Number of contractions are called as chronotropic. As you know that cardiac glycosides increase the force of contraction by increasing calcium. Hence we call as positive inotropic action. So chronotropic action is number. Cardiac glycosides has vagus nerve stimulation, releases acetylcholine. Acetylcholine decreases the number of heartbeats, called as negative chronotropic action. This is very important. Cardiac glycosides are having positive inotropic action and negative chronotropic action. Positive inotropic action, negative chronotropic action. So they increase the force of contraction, but they decrease the number of heartbeats. So don't confuse, that's what I'm telling. There is a lot of difference between the number of heartbeats and force of heartbeats. For CHF, we require only force. Cardiac glycosides are increasing calcium, increasing force, positive inotropic action. Cardiac glycosides cause vagus nerve stimulation, releasing acetylcholine, so decrease the number of heartbeats, negative chronotropic effect. If you see the pharmacokinetics, we all know that cardiac glycosides are high plasma protein bound drugs and they have narrow therapeutic index. So if the cardiac glycosides are high plasma protein bound drugs, what you can say is they have very longer duration of action. Narrow therapeutic index. If any drug is narrow therapeutic index, the drug is highly toxic. Because of high plasma protein binding capacity, they have very longer duration of action. Because of narrow therapeutic index, they are highly toxic in nature. So this is a disoxin and disoxin. The major difference is disoxin has one additional OH group compared to disoxin. Disoxin is more polar when compared to disoxin because it has additional OH group. Hydroxyl group increases means polarity increases. Side effects of cardiac glycosides. If you use cardiac glycosides, what happened? We told, use cardiac glycosides, you are inhibiting this. Sodium is present inside, calcium is present inside, but potassium is present outside. So that cardiac glycosides are having a severe side effect called as hypokalemia. Next is cumulative toxicity. So cumulative toxicity means the drugs produce toxicity due to accumulation of drug inside the body. Why the drugs are accumulated inside the body is cardiac glycosides are high plasma protein bound drugs. They have nearly duration of action for 3 to 5 days. They are strongly bind to plasma protein. They are accumulated inside the body. So that's why called as cumulative toxicity. So they produce visual disturbances, nausea, and vomiting. Coming to the drug interactions, cardiac glycosides should not be taken with diuretics because diuretics also have hypokalemia. We know that diuretics increase the excretion of water. Along with water, they increase the excretion of sodium and potassium. So all diuretics are having hypokalemia. Cardiac glycosides are also having hypokalemia. If you combine together, which will lead to severe hypokalemia. So cardiac glycosides should not take with quinidine because quinidine will stop the excretion of cardiac glycosides. So if you stop the excretion, cardiac glycoside concentrations increases. Cardiac glycoside concentration increases leads to toxicity because they have very narrow therapeutic index. So therapeutic uses. So as we discussed, they have positive inotropic action. Positive inotropic means what? Increase the force of contraction. That increase the force of contraction is required for the treatment of congestive heart failure. Next is negative chronotropic effect, means decrease the number of heartbeats. Decrease the number of heartbeats is required for the treatment of tachyarrhythmias. Clear? Positive inotropic property for CHF treatment. Negative chronotropic property for the treatment of tachyarrhythmias. But if you see in the classification of antiarrhythmics, we mentioned only class 1, class 2, class 3, class 4. but we have not mentioned cardiac glycosides. Reason behind is cardiac glycosides are highly toxic in nature. We are telling that cardiac glycosides are having negative chronotropic property. They are helpful to treat tachyarrhythmias. But practically we are not using for the treatment of tachyarrhythmias because of the more toxicity, very narrow therapeutic index. So we are using all these drugs for tachyarrhythmias like tachycardia, flutter, fibrillation. So all are tachyarrhythmias. So tachycardia means above 150 beats per minute, flutter above 300 beats per minute, fibrillation above 500 beats per minute. So all are tachyarrhythmias. So more severe form. Tachycardia above 150 beats per minute, flutter above 300 beats per minute, fibrillation above 500 beats per minute, more dangerous condition. So toxicity treatment. Suppose if you observe the cardiac glycoside toxicity, how will you treat the toxicity? So if you observe the toxicity of cardiac glycosides, we are using a specific antidote called as dizibind. And the cardiac glycoside toxicity is because of hypokalemia, so that we are giving the potassium supplements. If you observe cardiac glycoside toxicity, we are using a specific antidote for cardiac glycosides. We are using a dizibind. And to treat this hypokalemia, the toxicity is hypokalemia, we are giving potassium supplements. So coming to the second mechanism. So first mechanism is drugs which increase the levels of calcium. The next mechanism is drugs which increase the levels of cyclic AMP. Drugs which increase the levels of cyclic AMP. So as I told you, what is cyclic AMP, which is one of the second messenger in adenyl cyclase pathway. So ATP, by the action of adenyl cyclase, converts to cyclic AMP. I told you yesterday, the enzyme phosphodiesterase is involved in the inactivation of cyclic AMP. So ATP, by the action of adenyl cyclase, converted to cyclic AMP, it becomes inactive by the action of phosphodiesterase. So our concept is what? To increase levels of cyclic AMP. If you increase the levels of cyclic AMP, we can increase the force of contraction. How it is possible? By stimulating this adenyl cyclase, by inhibiting this phosphodiesterase. So we are increasing the cyclic AMP by stimulating adenyl cyclase or by inhibiting phosphodiesterase. So that we are using the drugs which stimulate the adenyl cyclase and which inhibit the phosphodiesterase. So we are using the drugs called as sympathomimetics. Selective beta-1 agonists. So I told in the receptors, pharmacodynamics, all beta receptors are GS. GS means what I told, increase levels of cyclic AMP. All beta receptors, beta-1, beta-2, beta-3 are GS. GS means increase levels of cyclic AMP. Beta-1 agonist means GS, increase the cyclic AMP. Sympathomimetics, where the best example is dobutamine. So next is phosphodiesterase inhibitors. If you inhibit phosphodiesterase, the levels of cyclic AMP will increase. So we have two types of phosphodiesterase, 3 and 4. 3 is present in heart, 4 is present in bronchi. So we are using the drugs which inhibit phosphodiesterase 3. Those are amrinone and milrinone. See, both are increasing cyclic AMP. This is GS, stimulation of adenyl cyclase, sympathomimetics, dobutamine. These are phosphodiesterase inhibitors. Wherever you inhibit phosphodiesterase, levels of cyclic AMP will increase. But we have to increase cyclic AMP in the heart by inhibiting phosphodiesterase 3. So we are using amrinone and milrinone. So one of the students mailed me about phosphodiesterase. So what is the use of phosphodiesterase inhibitors? This is what I'm telling. Whenever you are using phosphodiesterase inhibitors, the levels of cyclic AMP will increase. In the heart, if you increase cyclic AMP, increase the force of contraction that is required for the treatment of congestive heart failure. So this is what about the two different classes of drugs used for the treatment of congestive heart failure also. So once again, be alert. So today we completed the two disorders of CVS. One is about arrhythmias, another is about congestive heart failure. So once again, be here. So within 5 minutes, I will revise the things what we discussed so far from the beginning to here. So what is the normal functioning of cardiovascular system? Disorders, arrhythmias, CHF. And finally, I will show you some two videos related to our discussion. So all of you be active, all of you be attentive. Just I will revise the things, just I will revise all the things within 5 minutes, what we discussed so far. And after this revision, I will show you the two videos by which you can understand more clearly the mechanisms of all these. And then tomorrow we will see the remaining disorders of CVS. So be active and be alert. I will revise the things. See, drugs acting on CVS means which are used for the treatment of disorders. Disorder means altered function. First, we have to know what is the normal function of cardiovascular system. So, cardiovascular system consists of two major parts, heart and blood vessels. The major function of heart is pumping of blood. The major function of blood vessels is supply of blood. The blood vessels which supply blood to heart called as coronary blood vessels. The blood vessels supply blood to various parts of the body called as peripheral blood vessels. Coming to the disorders, congestive heart failure is a condition where the heart is not able to pump sufficient blood to various parts of the body. As a result, blood supply decreases to various parts of the body. So atherosclerosis means cholesterol lipids get accumulated in the blood vessels, especially in coronary blood vessels. As a result, blood supply decreases to heart, which is called as atherosclerosis. If you are not controlling atherosclerosis, slowly it leads to pain in the chest called as angina pectoris. If you are not controlling angina pectoris, so prolonged lack of oxygen supply to any tissue leads to death of the tissue, death of the myocardium, called as myocardial infraction, called as heart attack. So increased blood pressure called as hypertension, decreased blood pressure called as hypotension. Abnormal increased or decreased heartbeat is called as arrhythmias. First we'll speak about arrhythmias. If you want to understand the arrhythmias, first we should see how one impulse will be generated, how heartbeat is coming. So impulse generation takes place in cardiac cell, begins with the resting state, is minus 90 millivolts. First impulse generation begins with the opening of sodium channels, phase 0. Then sodium channels closed, potassium channels open, decrease in the potential, phase 1. Then calcium channels open, influx of calcium and efflux of potassium, no change in the potential, plateau phase, phase 2. Calcium get closed, only opening of potassium, continuous efflux of potassium, decrease in the potential, phase 3. Finally, Na plus K plus ATPase gets activated, which will keep sodium outside and potassium inside. Cell reaches resting state. Totally, we have 5 phases. Phase 0, 1, 2, 3, 4. Phase 0 due to sodium, 1 and 3 because of potassium, phase 2 because of calcium, phase 4 because of Na plus K plus ATPase. So this impulse will be generated in the SA node because which is having automaticity called as pacemaker, from which it moves to atria, AV node, bundle of his Purkinje fibers to ventricles. So because of this, the ventricles undergo contraction called as heartbeat or ECG. So persons will have arrhythmias, mostly tachyarrhythmias. Tachyarrhythmias reasons is excessive impulse generation, fast impulse conduction, echotopic foci. Bradari arrhythmias includes decreased impulse generation, slow impulse conduction, heart block. Most of the patients are suffering from tachyarrhythmias, so we have to decrease the heartbeat, we have to decrease the impulse generation by blocking any of the phases. So you are blocking zero phase by using sodium channel blockers. You're inhibiting first and third phase by using potassium channel blockers. You're inhibiting phase 2 by using calcium channel blockers. So we have four types of drugs: class 1 drugs, sodium channel blockers; class 2 beta blockers; class 3 potassium channel blockers; class 4 calcium channel blockers. So class 1 sodium channel blockers. Sodium channel blockers, therapeutically we have three uses: anti-epileptics, anti-arrhythmics, and local anesthetics depending upon the site of action. If they block sodium channels in the neuron CNS, used for epilepsy. If they block sodium channels in the heart, used for arrhythmias. If they block sodium channels in the local area, used as local anesthetics. Anti-epileptic cum antiarrhythmic is phenytoin. Local anesthetic cum antiarrhythmic is lignocaine. So class 4 calcium channel blockers used are only verapamil diltiazem. The dihydropyridines nifedipine nicodipine will block calcium channels only in the blood vessels. That's why they are not used for arrhythmias. So drugs for blood arrhythmias, heart block include anticholinergics and sympathomimetics. If you come into the CHF, the heart is not able to pump because of less force of contraction because of the failure of left ventricle. So that to treat CHF, we have to increase the force of contraction, but not the number of contractions. Always force of contraction depends upon calcium and cyclic AMP. So we are increasing calcium and cyclic AMP. The drugs which increase calcium are cardiac glycosides, which include digitalis, tropanthes, quilthivacia. How cardiac glycosides are increasing calcium is by inhibiting sodium potassium ATPase. If you inhibit sodium potassium ATPase, intracellular sodium will increase. As a result, intracellular calcium will increase. Cardiac glycosides are having positive inotropic action, negative chronotropic action. Increase the force of contraction but decrease the number of heartbeat. Next, they are highly plasma protein bound drugs, long duration of action. That's why they're retained in the body for a long time. They are very narrow therapeutic index drugs so that they are toxic in nature. Side effects are hypokalemia, cumulative toxicity, visual disturbances. They should not take with diuretics that leads to severe hypokalemia. So to treat cardiac glycoside toxicity, we are using a specific antidote called as dizibind, and we are using potassium supplements. And finally, the drugs which increase cyclic AMP. How will you increase cyclic AMP is by stimulating adenyl cyclase, sympathomimetics, GS, beta 1 agonist, dobutamine. Another is phosphodiesterase inhibitors, especially phosphodiesterase 3 inhibitors, which is present in the heart. If inhibit phosphodiesterase, levels of cyclic AMP will increase. So, force of contraction will increase. Those drugs are ambrinon and meldinone. So, with this, so we have completed the two disorders of CVS, arrhythmias and CHF. So tomorrow we'll see the rest of the disorders of CVS, atherosclerosis, angina pectoris, and hypertension. So by tomorrow, my pharmacology sessions will be completed. So as a part of some awareness and guidance to the GPAT, some topics will be covered here. So got my point. So first class pharmacodynamics covered, second class GIT covered. So today and tomorrow, CVS will be covered. Today, arrhythmias and CHF over. Tomorrow, I will discuss atherosclerosis, angina, and hypertension. So with this, these things will be covered. So as a part of some awareness and guidance to the GPAT, how to study the pharmacology, I given some systems as an example to way how to read the remaining systems also. So once again, I'm telling myself, Dr. Nagarjuna, I'm the coordinator for GPAT cell in Raipur, Anantapur. And myself and Venkatrao sir, yesterday taken pharmaceutics, we both are running and coordinating the Hyderabad Academy and online GPAT Academy. We are giving coaching for pharmacy students for GPAT for 60 days in online mode also. So these are all the contact details. So this is for calling purpose, this is for WhatsApp purpose, this is a mail ID. And finally, I will show you the videos pertaining to our discussion, which will give you some good idea about the discussion here. So all of you please be attentive and active. Just listen. Some videos I will show you. See here, one video related to this impulse conduction. How the ECG comes also, I told you. Yes, so impulse conduction and relation to ECG. How it happens is just see.
The cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as an electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals.
See, this is due to SA node. This is due to atria. Okay?
Spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the...
So this is the AV node. So now QRS is ventricular depolarization. This is ventricular repolarization.
AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular...
So clear, this is SA node, atria, AV node, bundle of his Purkinje, ventricular depolarization and ventricular repolarization. This is one impulse conduction, one heartbeat. This is one sign starts with the SA node. Okay, fine. So I will show you one more thing. So regarding this impulse generation, you have a look onto this.
The heart is essentially a muscle that contracts and pumps blood. It consists of specialized muscle cells called cardiac myocytes. The contraction of these cells is initiated by electrical impulses known as action potentials. Unlike skeletal muscles, which have to be stimulated by the nervous system, the heart generates its own electrical stimulation. In fact, a heart can keep on beating even when taken out of the body. The nervous system can make the heartbeats go faster or slower, but cannot generate them. The impulses start from a small group of myocytes called the pacemaker cells, which constitute the cardiac conduction system. These are modified myocytes that lose the ability to contract and become specialized for initiating and conducting action potentials. The SA node is the primary pacemaker of the heart. It initiates all heartbeats and controls heart rate. If the SA node is damaged, other parts of the conduction system may take over this role. The cells of the SA node fire spontaneously, generating action potentials that spread through the contractile myocytes of the atria. The myocytes are connected by gap junctions, which form channels that allow ions to flow from one cell to another. This enables electrical coupling of neighboring cells. An action potential in one cell triggers another action potential in its neighbor, and the signals propagate rapidly. The impulses reach the AV node, slow down a little to allow the atria to contract, then follow the conduction pathway and spread through the ventricular myocytes. Action potential generation and conduction are essential for all myocytes to act in synchrony. Pacemaker cells and depolarized, it has more sodium and calcium inside the cell.
See here.
And depolarize only when stimulated, usually by a neighboring myocyte. When a cell is depolarized, it has more sodium and calcium inside 90 millivolts.
See from here. So how the impulse generation takes place also they will show here. The resting membrane potential minus 90. See here.
Depolarize only when stimulated, usually by a neighboring myocyte. When a cell is depolarized, it has more sodium and calcium inside the cell. These positive ions leak through the gap junctions to the adjacent cell and bring the membrane voltage of this cell up to the threshold of negative 70 millivolts. At threshold, fast sodium channels open, creating a rapid sodium influx and a sharp rise in voltage. This is the depolarizing phase. L-type or slow calcium channels also open at negative 40 millivolts, causing a slow but steady influx. As the action potential nears its peak, sodium channels close quickly, voltage-gated potassium channels open, and these result in a small decrease in membrane potential, known as early repolarization phase. The calcium channels, however, remain open, and the potassium efflux is eventually balanced by the calcium influx. This keeps the membrane potential relatively stable for about 200 milliseconds, resulting in the plateau phase, characteristic of cardiac action potentials. Calcium is crucial in coupling electrical excitation to physical muscle contraction. The influx of calcium from the extracellular fluid, however, is not enough to induce contraction. Instead, it triggers a much greater calcium release from the SR in a process known as calcium-induced calcium release. Calcium then sets off muscle contraction by the same sliding filament mechanism described for skeletal muscle. The contraction starts about halfway through the plateau phase and lasts till the end of this phase. As calcium channels slowly close, potassium efflux predominates and membrane voltage returns to its resting value. Calcium is actively transported out of the cell and also back to the SR. The sodium-potassium pump then restores the ionic balance across the membrane. Because of the plateau phase, cardiac muscle...
Got it, Mike? So here the resting. Phase 0 sodium, phase 1 potassium, phase 2 calcium, phase 3 potassium. This is resting Na plus K plus ATPase. So see the last one. So regarding you can understand easily digitalis mechanism.
The cardiac conduction system consists of the following components: the sinoatrial
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create.
How digoxin acts as cardiotonic in heart failure. Digoxin is a cardiac glycoside. So it is a natural glycoside coming from the Distalis species. Chemically, it is having a structure like this, and one of the important nucleus it is having is the steroidal nucleus. And this steroidal nucleus is going to be connected with the 5-membered cardiotonic, and this is the outside of this membrane and this is the inside of this membrane. And during the action potential generation within the membrane, sodium is going to enter into the membrane where it causes a depolarization of these cardiac cells. So this phase what we call the phase 0. And phase 0 is followed by again the entry of the calcium into the membrane, which actually responds for the force of contraction of the heart. This phase is called phase 2, plateau phase. And finally, the repolarization of this cardiac membrane is mediated by the potassium ions which are going outside of this membrane. This phase is called phase 3, complete repolarization phase. In this way, ions can enter into the cardiac membrane and go out of the cardiac membrane to bring the depolarization as well as the repolarization. But once this action potential is complete, how these ions are going to be restored? We have seen that sodium and calcium are entering into the cardiac membrane and potassium is going outside the membrane. How they again be restored such that sodium and calcium are going again out of the membrane and potassium is coming inside the membrane. So this should happen in order to bring another action potential, because ions should be restored after the action potential. But at the same time, on restoring these ionic levels, the membrane potential should not be changed. This is carried by a few of the specialized systems, electroneutral pumps. Such type of pump that is present on the cardiac membrane is the sodium-potassium ATPase pump. This pump will pump the sodium ions which are entered into the membrane during the phase 0 to the outside of this membrane. At the same time, this pump can bring the potassium which is on the outside into the membrane where it is going to restore the potassium levels. In this way, sodium-potassium ATPase pump will work such that sodium is going outside and potassium is coming inside without any change in the membrane potential. And this pump is also working in coordination with the another pump, that is the sodium-calcium exchange pump. This pump will bring few of the sodium ions again into the membrane. At the same time, few of the calcium ions are going outside the membrane. Now these two pumps are working together so that they will bring the potassium inside and they will transport the sodium and calcium outside of the membrane to restore the ionic levels within the cardiac membrane. And one of the interesting points is that these pumps will not change any membrane potential, and the membrane potential remains constant. Even these pumps are going to transport the ions across the membrane. Now here the digoxin is going to show its action on one of these pumps, that is a sodium-potassium ATPase pump. So digoxin is going to bind to the potassium binding site on the sodium-potassium ATPase pump and inhibits the activity of this pump. So digoxin is competitively inhibiting this pump by competing with the potassium, and because of this inhibition of this pump, it increases the intracellular sodium levels. So sodium is going to be accumulated as this pump is not working because of inhibition by digoxin. As the intracellular sodium levels are going to be accumulated, this can inhibit the sodium-calcium exchange pump, which actually brings the sodium into the membrane. As already intracellular sodium levels are more, sodium cannot enter again into the membrane. This pump is going to be inhibited. Now when this pump is going to be inhibited, this results in the increased intracellular calcium levels within.
No, understood. See here, the sodium-potassium ATPase, so will bring sodium outside, will bring potassium inside. When the sodium enter outside, this sodium will come inside once again. When the sodium enter inside, this calcium will go outside. Try to understand. When the sodium enter outside, this sodium will come inside once again. The calcium go outside. But if you inhibit this pump, what happened? The sodium cannot go outside. When the sodium cannot go outside, automatically this cannot come inside. So automatically the calcium will not go outside. As a result, sodium will be present here. So when the sodium is present here, this sodium cannot come here, calcium cannot go outside. So sodium levels increases and calcium levels increases. So this increased calcium will increase the force of contraction. I hope all of you understand. So this is the way to understand all these disorders and everything and all. So fine. So with this we have completed the two disorders of cardiovascular system. One is arrhythmias and CHF in detail, as well as electrophysiology and everything and all. Okay. So once again, I thank to this government of Andhra Pradesh, Jain to Anantapur, Jain to Kakinada for providing this platform to the students and for inviting me to take the lectures. So thank you one and all. So tomorrow we'll see once again. Tomorrow is the last day. We'll see as much as possible. Okay, thank you one and all.